I'm going to try and go pretty quick. I want to make sure that we have time for the question and answer and for some discussion. And so I just want to hit some high points, and we are going to talk about human health today. You're going to hear a lot about animal health as we go along. And I want to talk a little bit about human health. At CDC, we just published a report, and I'll give you the URL for that at the end, just about 6 weeks ago. And for the very first time, we have put a number on the number of cases of antimicrobial resistant illnesses that occur in the United States and the number of deaths that result from those illnesses. And what we said in the report is that this is the minimum estimate. This is a very conservative estimate. And this is the first time we've ever done that. And you may say, well, what took you so long? The CDC is all about surveillance and tracking. One of the things that we'll talk about and that I want to stress really over the next 10 minutes or so is that antibiotic resistance may well be the single most complex problem in all of public health. And I can go into more detail about that later, but I think it's the single most complex problem. And just real quickly, the reason I say that is because in human health, we're basically dealing with a single genome. We're dealing with the human genome. We've just mapped that. We're dealing with human physiology. We're dealing with changes in human physiology. We're dealing with human mutations. We're dealing with the interaction between human beings and the environment. Tobacco smoke doesn't change. Trans fats are trans fats. But when you talk about antimicrobial resistance, you're talking about an incredible interaction between essentially all life forms on the planet. Bacteria are everywhere. We're talking about animals and humans here. The sheer complexity of that is overwhelming. And that's why this is the first time that we've been able, using a lot of mathematical modeling, in addition to our surveillance data, to put a number, a minimal number, on the number of cases of antimicrobial resistant illnesses that occur and the number of deaths. I'll come back to that in a minute. So it's 2 million, over 2 million is the minimal number of illnesses, and at least 23,000 deaths that are directly attributable to those infections. I'll go quickly on this. You folks know this, but I want to make one point on this slide, which is how antibiotic resistance occurs. The language that we use when we say the bacteria become resistant or develop resistance, that's the language we use, but it suggests a little bit in the way that we use language that the bacteria kind of get together and figure out how to fight the antibiotics. But what in fact happens is that antibiotic resistance is a naturally occurring process that goes on even in the absence of human beings giving antibiotics. The bacteria have had a few billion years to develop the mechanisms, the genetic mechanisms for developing resistance. The resistance already exists. What we do with antibiotics is kill off the bacteria that are not resistant and leave the resistant ones behind. So that's the point I want to make here. And this is a greatly oversimplified schematic of that complex system. And the point to make on this slide, because it shows antibiotics go here, and on the right-hand side is the human cycle, on the left-hand side is the animal cycle. The key takeaway, I think, from this slide is anytime antibiotics enter this incredibly vast, complex ecosystem, it contributes to resistance. Now, certainly, the use of some antibiotics in some settings contributes more to the development of resistance than the use of other antibiotics in other settings. But the use of antibiotics in any setting contributes to the overall presence of resistance in this incredible, complex ecosystem. There is no time when you put antibiotics into this ecosystem that it does not contribute to resistance in some way. We'll talk about that. So at CDC, we have 4 means in the public health system of addressing antibiotic infections. One is to prevent spread. The most obvious way to do that, for example, in hospitals, is through infection control. People washing their hands, using gowns, isolating patients that have very resistant infections. The surveillance that I mentioned before, the tracking, is incredibly important in helping us to understand the magnitude of the problem, where it occurs, and what we need to do to prevent it. The third piece, which I'm going to talk a little bit more about, is so-called antibiotic stewardship, improving the way we use antibiotics. And I'm going to focus in my talk on antibiotic use in human beings. We need to be better stewards of antibiotics. And I'm going to talk about that in a second. And the last is we still and will always need new drugs, as well as better diagnostic tests, but we're always going to need new antibiotic drugs because the bacteria have had several billion years to figure out how to always develop resistance. We're not going to prevent the development of antibiotic resistance. What our goal is to slow down the development of antibiotic resistance so that we'll always have new antibiotics coming along. What's happened in recent years is that the so-called antibiotic pipeline, the development of new antibiotics by the pharmaceutical industry, has slowed down for a variety of reasons that we can talk about. And we are now falling behind. In the 1960s and 1970s and into the 1980s, there was a profusion of new antibiotics coming along, so that in some sense we didn't worry that much about resistance. We said, well, if we have resistance, there's always a new antibiotic coming along that's going to address that resistant problems. That's not happening anymore. We are running out of new antibiotics. We have got to slow down the march of resistance so that we have more time to develop the new antibiotics. This is a map of the United States showing the number of prescriptions written per 1,000 people in the year 2010. This was published by my colleague Laurie Hicks in the New England Journal of Medicine earlier this year. There are 6 different colors on the map, and they show state by state the frequency with which antibiotics are prescribed. And it ranges from a little over 500 prescriptions per 1,000 people per year to over 1,200. So now in Oregon, people there get a little over 500 prescriptions per 1,000 people. In West Virginia and the other states that have the darkest color, they get over 1,200. Now, Dr. Hicks and her colleagues are going deeper into this data to look at why that occurs. But our hypothesis is that the people in West Virginia do not get 2 to 2.5 times the number of infections that the people in Oregon do. Now, we all know that doctors prescribe antibiotics when they shouldn't. We know that doctors are prescribing antibiotics for viral respiratory infections when they shouldn't do it. Antibiotics don't do anything for viral infections. It's a recurring problem, and again, there's an entire sociology and books written about why that occurs. We can talk a little bit more about it later. But if we can find out why the doctors in West Virginia are prescribing antibiotics 2.5 times more than the doctors in Oregon, that is going to help us figure out how to bring everybody not closer to the mean, but move them all toward the lighter colors on that map to reduce the amount of antibiotics that are used. What do we do right now? Right now we focus a lot on education. On the left-hand side of the screen, you see a handout that goes to physicians to help them understand not only why they need to use antibiotics more carefully, but how to talk to their patients, since patient demand is a key part of what causes doctors to write these prescriptions. And on the right-hand side of the screen, you see a brochure that goes to patients, especially to parents, to help them understand why they shouldn't be demanding an antibiotic when they go to the doctor. So that's the outpatient department. Those are outpatient prescriptions because the data that Dr. Hicks analyzed comes from retail pharmacies, your CVS, your Walgreens, places like that. In hospitals, there's decades of study that shows that up to 50% of the time when antibiotics are used, they're either not necessary or used inappropriately. Sometimes they're used too long. Sometimes it's the wrong dose. Sometimes it's the wrong antibiotic. Sometimes it's an antibiotic that isn't even directed at the bacteria that the patient has. And in a very recent study, that's been confirmed again in a pediatric hospital. Up to 20% of the antibiotics are not correctly prescribed. What are we doing about that? Well, in addition to education, I'll show you that in a minute, our tracking, we are developing a system to look at antibiotics that are used in hospitals, combine that data, and using a risk adjustment strategy, that is, looking at the patient population in the hospital and the different wards of the hospitals, we're going to use predictive modeling to say to hospitals, based on your patient population, this is how much antibiotics we think you should be prescribing over a certain period of time. We're going to use benchmarking. And what you see, this is a mock-up of what that system will look like when it goes online. And on the top line, for example, where you see the medical intensive care unit, the MICU, in this mock-up, the hospital would have used 4,000 antibiotic days, just a measure, but they would have used 4 times as much as what would have been predicted based on the patient population in that intensive care unit. And so the hospital will get a printout like this that says, in your medical intensive care unit, based on the predictive modeling, your antibiotic use is 4 times what it should be. Now, that doesn't automatically mean that that's wrong. It means that the hospital needs to look into that and figure out what's going on. What's going on there? Odds are that there may be a problem in prescribing antibiotics. You don't want to rule out the fact that, in all the intensive care units, there may be an anomaly. There may be something strange going on during that period of time when you were doing the measurement, a strange outbreak in that hospital. But it's a signal that the hospital needs to do more to figure out what's going on. The educational efforts in hospitals center on a number of things. One is why you should do stewardship, why it's important for preventing antimicrobial resistance, but also it saves money. In a healthcare system that we know spends more money per capita than any other health system in the world, saving on not prescribing antibiotics that aren't needed is going to save a considerable amount of money. And where that's been put into effect, hospitals have saved a tremendous amount of expense at no detriment to patient care. We also talk about antibiotic safety. Antibiotics are unique in some ways. Nobody would go to a doctor and say, doc, I think I might have a heart condition, so give me a powerful cardiac drug. Or, I might have asthma. I don't know if I do. You don't know either because you haven't tested me, but give me an asthma drug. We don't do that. There's no other class of drugs that we go to doctors, and people do it all the time, say, I might be coming down with a cold. I'm not sure. Give me an antibiotic. It's a unique class of drugs. We don't treat them like any other drug, but they are like any other drug because they have side effects, they cause allergies, they interact with other medications that people are taking. So when we talk about antibiotic safety, we're trying to help people understand that these are not risk-free drugs, not just because they contribute to antibiotic resistance, but they can have a detrimental effect on the person who's taking that drug. So asking for one when you don't need it threatens your health. So that's where we are now. What does the future hold? There are a number of efforts underway to help reduce antibiotic use in human health. Formulary restriction. A lot of places practice this right now. In hospitals, if you're a doctor, you can't write for any antibiotic you want. The formulary, the number of drugs of antibiotics that are carried in the pharmacy, is limited to a certain number that address every problem. But there are more antibiotics out there. You don't need 3 different types of so-called carbapenem drugs. Some are more expensive than others. So restricting what doctors can write for on the formulary is one. A prior approval system is in some hospitals. Doctors have to get approval from a specialist to write for certain types of antibiotics. A third are so-called timeout programs, that an antibiotic order automatically stops after a certain amount of time to ask the doctor to go back and review the order that she's written 2 or 3 days ago and not let it just continue unchecked. Go back and look at that order to make sure that that antibiotic really is necessary now that you have more test results back. And the last is the education and the benchmarking, which I talked about. And in the future, states are looking at antibiotic use as a component potentially for looking at licensure of healthcare facilities. Hospital accreditation standards. Under discussion is the use of antibiotic use, improvement use programs as part of an accreditation program. And reimbursement from third-party payers. Should all antibiotic prescriptions be reimbursed irrespective of whether they're necessary or not? All of those things are under discussion. Some of those things are being piloted in various places. But it speaks to the commitment that not only those of us in public health, but more and more throughout the healthcare system, the commitment to changing the way antibiotics are used in the United States, both for safety reasons and because, as I said, every time an antibiotic is used, it contributes to some extent to the development of antibiotic resistance. So we're working on that, and at the bottom of this slide are the 2 URLs. One is for the general drug resistance site, www.cdc.gov/drug resistance, and on that site you can get access to the AR threats report, which a lot of these illustrations came from, that we just released 6 weeks ago.